Welcome everybody to the new Retina Radio Journal Club with VBS. I'm Kyle Kovacs, your host from Weill Cornell, and we are absolutely delighted to have an esteemed group of panelists here with me today. First, we have Cynthia Qian, an associate professor from the University of Montreal.
Hi, Kyle. Thanks for having me, and it's great. Looking forward to talking about these subjects with yourself and David.
And right on cue, we also have David Chu from Mid-Atlantic Retina and Wills Eye Hospital.
Hey, Kyle. Hey, Cynthia. It's good to see you guys. It's such a pleasure to be with you guys all today.
A few notes on what we're going to be doing today. So we're going to succinctly kind of go over a couple different journal pieces that have come out or will be coming out in the near future and have a little discussion about them. First, we're going to summarize some of these journal pieces. We'll take a quick break afterwards and then have a longer roundtable discussion where my brilliant colleagues are going to tell me exactly what I should be doing based on the journal findings that we're going to be discussing. So let's get started and hop right into it. Let's kick off the discussion with some of these literature articles. The first paper we have is entitled Outcomes of Eyes Undergoing Multiple Surgical Interventions After Failure of Primary Rhegmatogenous Retinal Detachment Repair by Emma Stenz et al. And it has just come out in May 2022 in Ophthalmology Retina. I wonder if I get Cynthia to maybe summarize some of this and kick off our discussion.
Yeah, sure. So let's delve right in, since we all love talking about retinal detachment surgery and how to repair it. So this was a retrospective consecutive case series of patients from a practice with multiple retina specialists with cases dating back from 2016 up to 2020 that failed after primary RRD repair and that underwent at least two repair surgeries. So in this group, they actually identified out of all their over 2,100 patients, 166 eyes in 164 patients who needed two or more retinal repair surgeries. So going over the findings, the high level conclusion, well, first of all, the good news is that single operation success rates were very good and comparable to the numbers that we see floating in literature. So 93% of the patients were reattached successfully after one surgery and remained so for the remainder of the study. And for those who needed further repairs, after a second repair, the success rate anatomically was 72%. And after 3 repair surgeries, the success rate was 68%. So what they found is when there were multiple surgeries that were needed, the final anatomic success was quite similar in those, whether it was 2, 3, 4, or 5 surgeries, and the success at the end of all the surgeries was close to 96%. So that's a pretty good number, above 90%, above 95%. And they also looked at postoperative visual acuity that was assessed in months 3, 6, and 12. And what they noted is that obviously after 1 or 2 surgeries, there was on average a gain in mean gained visual acuity. But once further additional repair surgery stacked up, that gain in vision was starting to stagnate and began to be lost. So up to 2 repairs, there was an average of 0.12 logmar of visual acuity gained. If the patient or the eye needed 3 repairs, there was no change from the baseline vision at presentation with the detachment. And once you reach 4 or 5 repairs, there was loss of vision compared to baseline. And what was also interesting was that they noted that during the second surgery, the eyes that were under silicone oil endotamponade, that being either 1,000 or 5,000, seemed to perform significantly better than eyes that had C3F8 or SF6 gas in terms of whether they needed another surgery. So 20% were less likely to need a third surgery if they had silicone oil versus C3F8, and 38% less likely to need a third surgery if they use oil versus SF6. That's quite interesting, and I'd love to hear your thoughts on that later on. And eyes that developed a third retinal detachment due to PVR were actually significantly more likely to need further surgeries than eyes that developed another RD because there was a tear or just a new finding or a failure to reattach from the prior surgery. So the main conclusions that we could draw from this was that the final anatomic success of these cases was quite good and was similar in eyes that were achieved with more than 2 surgeries versus those that were just single surgeries. And the visual acuity improvement, was increasing up until about 2 surgeries, but after that began to decrease with the higher number of surgeries. And finally, tamponade choice seems to make a difference and be a key in the reoperation rate, as well as the presence of PVR at the initial baseline presentation, which also was a prognostic factor for the recurrence rate of RRDs. That's it, guys. So thoughts?
Great. Well, thank you, Cynthia. PVR, I feel like, is the one thing that we hate to love to talk about as retinal surgeons. David, I wonder if you have any thoughts or reactions to some of this data.
I think it's really interesting, and it plays into the central question of what happens to our reoperations. There's so much literature, first of all, focusing on the single operation anatomic success. So what happens and how can we decide on doing one surgery, which is still the best. I totally 100% agree with that's the most important thing, how to fix these eyes. But after they undergo 1, 2, 3, or even more reoperations, what are their outcomes? And I love that it's addressing this. And I think that it becomes increasingly more heterogeneous as we go through more surgeries. And so I love the difference in terms of looking at the visual outcomes, the anatomic outcomes, and also the tamponade choice. And I do think that's really an exciting one. One follow-up question I had for the group was, for me personally, when I detect that there is PVR as a result of a redetachment, right, that's what's causing the redetachment, I'm, for that second surgery, almost always using silicone oil. If the first surgery involved vitrectomy, not, for example, a scleral buckle, but I'm almost always using silicone oil. I don't know what you guys think about that personally.
I agree wholeheartedly. Certainly, if there's already PVR, they're getting oil for sure. The real question for me from this study is whether or not, in an eye without PVR already, the data here is suggesting we should be leaning towards silicone oil, even if it's just that it can do break. Sorry if you would think otherwise, Cynthia.
I mean, I think, as David was saying, this is a quite large group, and they're looking at multiple factors, and obviously they're looking at multivariate analysis, and it's hard to kind of dissect different factors one from another. I think they're all sort of interconnected, and it's hard to say whether, as you said, the silicone oil, is it interdependent or independent from the other factors, and sort of warranting, like you said, even for primary repairs and detachments. And what I also thought was interesting, and David briefly mentioned, is also the use of scleral buckling. That wasn't really the focus of the paper, but they did mention that again, there's a large group of surgeons. Some perform buckling early on, others do scleral buckle vitrectomies on 2nd, 3rd, or 4th. So obviously, I think those are also influencing, the rate of recurrence, the PVR development. And I was actually curious about what your thoughts about, combo cases were, and do you add that on pretty early on, or are you kind of a vit till surgery number 5, number 6 type of person?
Well, let's put that discussion of the artistry of when to put on the scleral buckle for the panel discussion in a little bit. I want to move on to the other paper that we mentioned, so that we have a little bit more evidence for our discussion. This is entitled Factors Associated with Good Visual Acuity Outcomes After Retinectomy in Eyes with Proliferative Vitreoretinopathy. And the lead author is Rachel Israelovich. This is coming out in the future in American Journal of Ophthalmology in August 2022. David, I wonder if you could take us through some of the findings from this study.
Thank you so much, Kyle. Yeah, this is a wonderful paper, and I really love it. So as you said, the first author is Rachel Israelovich. She's actually a 4th-year medical student at Jefferson. And as a matter of fact, I ran into her earlier this morning during her rotation. She's applying for ophthalmology. I've published with her personally. She is wonderful. And the senior author is Jason Shu. And I was with my colleague, Dr. Shu, when I was a fellow, actually. And it started, the genesis of this interesting study was really the question. It really stemmed from one key clinical question, which is, classically, we think of retinal detachment repairs, and we all think about anatomic success, right? did the patient stay attached for the rest of the patient's life? But this is addressing it from a very unique and specific focus, which is how good are patients going to see afterwards, number one, and specifically in the setting of what we believe to be a severe recurrent detachment associated with PVR that was so significant it required retinectomy. And so when we think of severe recurrent detachments requiring retinectomy, I mean, I think for certain surgeons, the thought is, man, that's a pretty sick eye now, and we're really fighting for the anatomic success. How are we ever going to be able to, get them even on the eye chart at all? And so this was a study addressing that specific question. We found that the minority of eyes who were able to achieve 20/70 vision or better in the cases of recurrent PVR detachment requiring retinectomy was on the order of about 18%. So it was less than a quarter of patients were able to achieve that level of great vision, but it's not zero, and it's really something to really aim for. And the other interesting thing about this paper is, unlike so many retrospective studies, it was a true case control study. I mean, I just don't see that very much in the literature these days. And what the authors here did was they took patients that were able to achieve that visual threshold and compared against patients who were not able to achieve that 20/70 visual threshold and who were matched in terms of age as well as gender, age within 2 years. And they looked at, again, patients who had recurrent detachment, but were not controlled for all the other RRD anatomic factors that may or may not be associated with the development of eventual good vision. And so they analyzed this out of a cohort of about 5,500 eyes, and eventually the population that they had available for a study was pared down eventually to just 62 eyes that for the good vision threshold, and they had about a 2-to-1 control versus case sample. So what they did was a univariate as well as multivariate analysis, looking for those predictive factors associated with good ultimate vision. So as far as the univariate correlates, it was a faster mean time to the second surgical repair after the diagnosis of the recurrent detachment, a smaller mean size of the initial retinectomy that was made, fewer subsequent repair surgeries, a higher likelihood of having a macula on initial presentation, which certainly makes sense. And then on the multivariate analysis, they found, I think that's the most important thing out of this study, which is what are the significant correlates here? It's the size of the initial retinal detachment, the number of overall surgeries, the time, again, between the diagnosis of the recurrent detachment and the surgery itself, the preoperative visual acuity, which probably correlates with presenting macula status as well, and pseudophakia, which also, of course, makes sense when you're talking about multiple vitrectomies, retinectomies, oil, and things of that nature. So I think that's ultimately the findings. And I think out of all of them, some of them you would really say that does make sense. I can believe pseudophakia makes a contributing factor, but I think the key one is the timing between diagnosis of retinectomy, diagnosis of recurrent detachment and the surgery itself is a predictive factor. And I think that's the key takeaway is to be sooner, to bring these patients back into the operating room rather than to try to let the membranes mature or things of that nature.
Great. Well, thank you so much, David. Cynthia, I don't know if you have a quick take on what David just presented to us.
Well, first of all, I'm happy that David is the one summarizing this data. I mean, this real-time update from authors with the Wills crowd, I think is very much appreciated. If you can get actually live updates, maybe this is really insider information, so that's much appreciated. I think that the study design is quite rigorous, and I like that. And I think using good visual acuity as a outcome is really something that's important. In the prior study, we were talking a lot also about surgical anatomic success, but I think from obviously the patient's point of view and from the long-term outcome of, what the patient sees, good vision is really what matters, on a day-to-day functional level. So I think it was really interesting to look at the information from that perspective. And I think just the data, as you said, the conclusions make sense, but also to have such a well-designed study sort of, confer and confirm those findings is really something I think that we can stand behind. And going forward, it's really, a good piece of publication that we can depend on for future practice patterns, as well as, the time to recurrent surgery, as well as, when to practice retinectomy versus some of the other factors we want to incorporate into our practice.
Great. Well, thank you, Cynthia. On that note, let's take a quick break. On the backside of this, we're going to get into some more uplifting discussion of PVR RDs with our panel. We were just presented some interesting data on PVR retinal detachments and simultaneously the bane of retina surgeons' existence, and yet the thing that we end up talking about the most, I feel like spinning in circles. There's a couple items that started to come up in our discussion of some of these papers, which we started to get into a discussion of. And I think one of those is from the first paper, the Stents paper, about the use of silicone oil as the primary tamponade in a second RD surgery, maybe with a more favorable outcome. I don't know if this would sway either of you, Cynthia or David, to maybe consider that being a uniform primary tamponade for a second RD surgery.
Like I said, I do really like silicone oil for the second one, especially when when PVR exists. And I think that's the vast majority. I hope that we're not dealing with situations where it's basically two other situations, right? Failure of attachment of a primary scleral buccal for various reasons there. And that's not necessarily due to PVR. And a second is missed breaks, which if caught early enough is also not going to be associated with PVR. In the absence of those two specific criteria, I think the vast majority though are times when I do use silicone oil for better or for worse.
Yeah, I agree, David. I mean, I think for the patient as well, right? I mean, most of them, by the time already when the second surgery rolls around, they're highly motivated to go through a surgery that, first of all, leaves a tamponade agent that has a more predictable course of, staying power. Obviously with gas, the advantage is that it evaporates. You don't have to go in for a second surgery. But by the time they get back to a second surgery, there's recurrence already. The goal is really to have the best outcome for retinal reattachment. And I think in my personal experience and those of my colleagues, very often silicone oil would be the best choice.
I'm wondering for Cynthia and Kyle, when are the situations when you put on a scleral buccal during a reoperation? That's something not directly addressed by the paper, but I'm just curious.
It's a good question. I mean, first of all, looking at the numbers from the paper, I'll just quote the numbers and see whether that aligns with what you do, right? So they were saying for their second surgery, by then 35% of the cases would have had a scleral buccal put on. By the third surgery, 87%. So pretty much, I think sounds like a third of the cases will have either a combo case by the second surgery, and then almost everyone universally earns a buccal when it gets to the third step. So yeah. I think that's pretty much in line, with what I do. I mean, I would say in my practice, vitrectomy is still king, but most people would obviously unless there's special conditions, age of the patient, the status of, the hyaloid and the sort of the amount of pathology, most would start with a vitrectomy first. But I think definitely by third repair surgery, the patient warrants a scleral buccal, and by the second surgery, it's a case by case. It depends on the patient and on the pathology I see. You guys?
I can't think of a recurrent RD that walked out of my OR or was wheeled out without a buccal also on that eye. I just well, first of all, if it was a vitrectomy for the primary surgery and the vitrectomized eye starts to detach, usually there's a lot of detached retina when you come back in. I'm always fearful there's micro breaks or small. And at this point, I feel like it's a belt and suspenders approach to getting the retina to stick on, as we'd have data to show, we're starting to go down a path of, a downward spiral. So I can't think of one. I've actually had more cases of patients with a small recurrence that were more of a pneumaticable in the office fix, right? Anything that could have been fixed with just a straight vitrectomy without the buccal with a recurrence of an RD is closer to a pneumatic in my hands than it is, a vitrectomy without, obviously in the absence of PVR, but everybody gets a buccal.
David?
I think I'm between you guys. I'm somewhere in between. I generally, if the eye looks like it requires a retinectomy, it doesn't matter the lens status. In the second surgery, if they didn't get a buccal, I usually don't do one. I just go to retinectomy because I think it's more posterior for the most parts, except for the two retinectomy edges, which are fairly high up and well supported by any endotamponade agent. But in cases where I think that I can get away without doing a retinectomy, then almost always, if they don't have a buccal, they're getting a buccal. getting a posterior and relatively high, relatively aggressive buckle to try and as much as possible salvage that retina without retinectomy personally.
I was wondering, do you do buckles in cases that already have some amount of retinectomy as well? Would you put on, do you have a cutoff of how much retinectomy is just retinectomy and vitrectomy, or could still benefit from scleral buckle support?
I think that's case by case personally. I will say that I personally have also added scleral buckles after I start the vitrectomy. That's generally on the primary, not generally speaking the second, because that's just quite an uncommon scenario, but I wouldn't be against it. And if it turns into a retinectomy that can be fairly anterior, pretty close to the vitreous space, where there is some buccal effect that reasonably could be obtained, I would say absolutely I would go for it. I mean, and plus with oil.
David, you made one comment earlier that struck a chord with me, which is talking about that first recurrent detachment and the fact that you said if you catch it early, then maybe you don't have PVR yet, right? But yet is the key thing. I always feel like when I'm reading data from these studies about the presence of PVR is the causative etiology for recurrence, right? That it's always really hard to tease out because, at some point when you have a recurrent RD, there will be PVR, whether it's causative or not. And I don't know how much that role of the causative PVR versus just the presence of PVR is important in dictating, understanding the etiology for recurrent RD, because I think the management is sort of the same. But I wonder, you started to allude to that ticking clock in your head about looking at a recurrence and how long has it been and what is our PVR clock. I don't know how any of the data from these studies or what your personal practice pattern is, how you hear the hooves, charging behind you of PVR with the recurrence.
My gosh, I couldn't agree with you more. I just think that I'm pushed to try to find an analogy of some sort of as much poorly understood and mistaught term as PVR, because it describes so many different things: primary, preoperative, PVR that's led to a detachment, and as you said, continued intrinsic contracture, as well as surface proliferation of membranes that also lead to contracture secondary to a recurrent detachment that happens afterwards. And this spectrum of different physiologic effects is just so interesting. And my gosh, I mean, they should be different terms that describe a slightly different thing, and yet we just use this amorphous term over here. But to your question, I mean, I think that the paper over here does suggest, I think, a really important lesson, which is that you should never try to let it mature. And I think you should try to take them back to the operating room, because I think that only leads to increased chance for probably macular involvement. As the data shows, leads to worse visual outcomes and decreased chance of them hitting that magical 20/70 mark. By the way, that I think is just a binary way to a binarization of a continuous spectrum of visual acuities, but better visual acuities nonetheless.
Cynthia, how would you, this is a lot of information that we think about very objectively in terms of outcomes. How would you start or try to break this down for a patient, right? When you're going into your second surgery, to set the tone for them and to try to integrate this into your counseling, like what the road that we're headed down?
I mean, I think, Kyle, sometimes, these patients, especially I would say post-COVID, some of them come with pretty chronic pathologies, even on first presentation. So, or, it's inferior, it's been sort of slowly brewing for a while. So you have a feel already that this is probably going to be, like a PVR fest with soup and likely to require multiple surgeries. So I tend to try to set the tone relatively early, in the sense that even from the first surgery with the planning, I give them the numbers, but say that this could be a multi-step approach, that basically our goal is not to, the ultimate goal is to have as good vision as possible, but our goal right now is to increase the chances of retinal reattachment, be that, multiple procedures together, buckling, vitrectomy, or multiple steps of surgery with tamponade, which will ultimately perhaps need to be removed. So I try to give them, I would say I try to give the lay of the land with the most amount of steps possible, and say that, we kind of use whatever parts of that equation best fits the patient, so that, it will be adapted for their needs and for their eye, but ultimately that it could be a multiple step process so that, we set the realistic expectations and that they can expect the best possible vision at the end of the process, but they're not looking for, that great vision, say that's 20/40 post, say, primary surgery, and then they redetach under gas, and now they're totally, redetached, and then their visual outcomes will only be less and less good with every subsequent surgery that we need to perform to fight off the PVR.
Well, I think with that, we're going to start to bring it to a close here. I'd like to thank my panelists here, David and Cynthia, for some really insightful commentary and really great presentation of some interesting data on PVR-RD repairs. I also want to thank our audience for listening to the New Retina Radio Journal Club with VBS, and stay tuned for further upcoming episodes.